So, dear friends, I have a serious problem. I have a serious problem because I know we're going to have a very interesting discussion, Mr. Montmarquet and myself, but I did not expect to have this discussion with Marc-André. You've heard, he said that the Quebec plan is a universal plan. We'll have to come back to that. So what I intend to do with you is to briefly try to see what are the four basic principles of the Quebec plan that are in the legislation. So we know that the plan has been in operation for 15 years. So that gives us lots of data to be able to assess the plan. The plan has been developed by Mr. Castonguay in his 1996 report, which was really the blueprint of the plan. If you read the report, you see the plan and the provisions of the Act. Now, it's always difficult to look at a plan, an insurance plan, and we all recognize it. There has been a step forward with that plan, and we have to keep repeating it. And we always agree, we all agree, the major benefit of this plan is that the whole of the Quebec population is covered, which is a major advance. But my comment is that it leads us to an impasse, to a cul-de-sac, because it may be positive, but are we in an impasse or not? So, three major plans in Quebec. You have the hospital insurance plan, the medical plan, and then the drug plan. And this is where I'll have a different position than Marc-André, because I always tell my students, if you hear someone say that the drug plan is a universal plan, please stand up and say, no, it's wrong. Because our plan is not universal. And that is the major issue that has to be understood. Because with this plan, we see that there's a major change of direction, really huge change of direction that was never seen in the health field, because we moved from the concept of a universal plan with hospitals and physicians to a general plan. And the difference is absolutely basic, essential. In this general plan, you find one of the characteristics of a universal plan, which means that everyone is covered. But if you read properly the way that universality is defined in the Canadian Act, you will see that that is not the only condition. There are two conditions for a plan to be universal, that everyone has to be covered, and then everybody has to be covered according to the same system, the same rules. And this is where the Quebec plan goes into a different direction, because lots of different groups will be created with different provisions for each of them. And that component is related to the role of insurance, because the matter of insurance is not how it is perceived, it's how effective it is. In the hospital plan and the medical plan, the basic plan is public, and there is private insurance, but it's not only put aside, it is forbidden. There are provisions in the legislation that prohibit that. And in 80% of the market in Canada, it is prohibited. Private insurance is prohibited. So in the universal regime or plan, private insurance is put aside. Whereas in a general plan, such as the drug plan in Quebec, various markets are reserved to the private sector. This is absolutely the opposite of what we want from a universal plan, because those are markets or first choice markets that are reserved to private insurance and with captive clients. Because once your employer provides the plan, you have no option. You have to be a member. It is compulsory. So that is the characteristic of the general plan in Quebec. So I come back to my 4 major characteristics of the drug plan. First, the systemic triage of risks. If you take an overview, there are obviously various situations where employers have to insure AIDS patients, for instance, as Marc-André said, but that is not the major characteristic of the plan. The plan is that the good risks are given to the private insurance company, because you're talking about people at work who have jobs. So when they have jobs, if you know the determinants, social determinants of health, you know that bad risk will be reserved to the public sector when you talk about the elderly and low-income persons. So the plan provides that separation immediately, right from the start, and that is a basic dichotomy in the legislation. Good risk to the private sector, bad risk to the public sector. That is a way to describe that with the terminology of insurance, but you can use another terminology. You can use the terminology of social insurance, because when we adopted systems and we moved from a social insurance system to another system, that drug plan brings us back to the idea, the principle of social insurance, where we're dealing with the poorer persons of society, lower income people. We can also say that this regime is not a plan of distributive justice, which had been implemented in Quebec from the Quiet Revolution. So we are moved back to what existed before the Quiet Revolution. So that was the first characteristic. Second characteristic, it's the taxation of the funding system. Because what we saw with the universal health insurance, we have a funding structure copied from the private insurance system. So you say, well, it's normal, because if the private sector has 60% of the market, well, it's okay. But the same system has been implemented for the public sector, with premiums, with the deductible, with co-pay, co-insurance. You will say it's okay for the private part of the plan, but in the public sector, the premium is capped, but the link between premiums and income is really at a minimum. Also, there is an apparent disconnect between taxation and the plan, because we've taken the funding model of the public system, copied from the operation of the private sector, of the private insurance sector. But if I look at the medical insurance since 1998, right from the beginning, even in 1998, the premiums covered only 30% of the total costs of the system. And I'm not including the deductibles paid by patients. I'm talking about public costs. And today, even if we increase premiums and co-payments, this contribution only covers 23% of the costs of the system. So this funding model, copied from private insurance, is a joke, because it does not cover enough. Third characteristic, the taxation tools of the public sector have been granted to the private sector. That is compulsory insurance, and co-pay. Usually it's called taxation. And it is paid at the source also. It looks like union dues. Same system. And obviously the private insurer receives the benefit from that structure of having to manage only group plans, because people who cannot afford group plans, they go to the REMQ. And the fourth characteristic is what I would call that a full disconnect and full ending of solidarity between the Quebec population, all the members. Because you can see that from two aspects. First, about synchronization, there is no interfunding between the private part and the public part of the plan. Those two sectors are really separated. But even in the private part, there is segmentation of the markets by companies, by corporations. So if you work in a company where, and you can refer also to social determinants of health, again, in some companies, workers may have more needs as far as drugs are concerned, but they will usually have lower salaries and will have to contribute more to pay higher premiums than people in other companies with higher income and with lower health needs and drug needs. And all this is really in the basic system. It is in the legislation right from the start. And a general plan means that you have a basic plan, and for the public part, it is the basic plan. But in the private sector plan, you can have the basic plan plus, 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 plus. If you have enough financial resources, financial capacity, which is very often linked to lower needs for drugs. So instead of contributing to those who need more, you provide additional benefits to those who do not need them. And this is why in many private sector plans, when you look at the needs, you have things that look absolutely crazy, like massages are covered and spas are covered and stuff like that. Because those plans have an additional funding capacity that the other part of the plan does not have. So that was the first aspect. Now, second aspect, there is a basic absurdity, full absurdity, in the concept of the plan. Because young cohorts, young workers, can pay premiums without planning for their later age. Because once they reach 65, they will be excluded from the plan and they will end up on the public regime, public plan. So there is a full absence of solidarity. This system, which I would call socially dysfunctional, is now presented by some people as being a new model that could lead to a revision of our universal health insurance system, or medical insurance, or hospital insurance. Mr. Claude Castonguay suggested that model in various reports, especially on his report on the funding of healthcare. And as I said at the beginning, it was the step that we should not have taken, because it will lead to a destruction of a universal public plan. And you only have to read the report of Mr. Montmarquet that had been asked for the 5-year review of the plan, and that is the conclusion of Mr. Montmarquet. So I guess I've laid the table for Mr. Montmarquet, actually, so I will leave him the floor. Thank you.